excitement and enthusiasm. There was, so many great questions and hopefully good answers for your questions. But I thought it was a really, really special couple of days. And so good to see so many of you all again for the first time virtually since then. So yes, today we have a special guest, Aaron Goodman. Aaron is a tremendous hematologist oncologist who practices in San Diego, and he's been just a great friend and partner to the CDCN for many years now. He's been seeing Castleman's patients for pretty much all of his career. He started getting interested, I believe, during his fellowship, and has continued to see a number of patients. There actually maybe some on the line who've spent time with Aaron. And we thought that this would be a good community gathering just to keep the Ask Us Anything theme going that we use at the Patient Summit, where you can just ask anything that's on your mind. We'll try our best to give the best answers we possibly can. Maleva, should I turn it back to you?
I'm actually on another call real fast, but I'll talk to you for a few moments.
Yeah, I'll take over just for 2 seconds, and then I'll kick it open to the community. So just 2-3 housekeeping stuff for everybody. For the question and answer sessions, we really want to not have it personal medical advice. So any questions that you guys are going to ask, try to keep it like more general about Castleman disease, things you want to know. It can be things that you guys have experienced, but we do not give out personal medical advice. So consult your own healthcare physician when you want to have a specific question about your own yours or your loved one's battle. Also, if you're comfortable asking your own questions, please feel free to unmute and ask. If you are not, that's totally fine. I'll moderate. So put your question in the chat. I will read it out loud, and then either Dr. Goodman or Dr. Fagenbaum can address those. And finally, if you're not asking a question, make sure you're on mute so that we can ensure that everybody can hear both the answers and the questions that are being asked. Outside of that, David, if you're comfortable, we'll just open it up to questions.
Yeah, it sounds great. Maybe even before that, maybe I'll just turn it to Aaron just for quick. Aaron, any other comments that you want to share before we turn it to the community?
No, well, thanks for having me. And like David said, you all know he's a champion of Castleman's. I got involved in this disease in fellowship from a mentor, and have since, I always feel weird, like that I'm no super expert in this disease. But I guess if you've seen a few of these patients, you've seen more than most physicians. And over the years now, I have quite a collection of Castleman's patients. And what I'll say is every case has been surprisingly unique, challenging and very rewarding to take care of this and sees dramatic improvements in this disease over the years. So thanks for having me. And I always love talking to patients.
Yeah, thanks so much, Aaron.
Okay, so we'll open it up to the community. Like I said, if you want to just unmute and ask your question, please feel free. If you aren't comfortable with that, that's totally fine. You can put it in the chat, and I will make sure to read questions out loud to our panelists.
Maybe while you guys are thinking of your first question, I'll just share really quickly a research update, and hopefully it'll get you guys thinking about questions to ask. Just this past week, we published a paper where we reported how when patients are on cetuximab, their IL-6 levels go really, really high, regardless of what's happening. So just being on cetuximab causes your IL-6 levels in the test to go really elevated. It doesn't mean you actually have increased IL-6. It doesn't mean that you're having a relapse. It just means that when you're taking the infusion of cetuximab, your levels will be falsely or spuriously elevated. And this is really important because over the years, we've had doctors come to us and say, my patient is doing great on cetuximab, but they're relapsing because their IL-6 levels are really high. So I'm going to give them a different treatment. And we say, no, don't do that. The IL-6 levels are not really high. It's a result of the way that the IL-6 binds to the antibody and therefore causes the test to think that it's high, but it's not actually high. So anyway, I'm sure you've probably heard me say this before, but we're excited that's now out, published. So any doctor that Googles Castleman's and IL-6, they'll hopefully quickly see that cetuximab causes spuriously elevated IL-6. It means nothing. You have nothing to worry about. It really means you just shouldn't measure your IL-6 levels once you're on cetuximab, and you definitely shouldn't worry about it.
And David, outside of diagnosis, I don't see any really role in IL-6. There's another test called ESR, which is much cheaper and just as useful, and that usually tells the whole story.
Totally agree. So don't measure IL-6, and if your doctor measures IL-6, tell them not to pay attention to it if you've been on cetuximab or tocilizumab.
Great. We actually have some questions coming in. So I think that was a great way to kick us off, David. So one of the questions is, how can we shrink our swollen lymph nodes?
So, Aaron, please take that one.
Yeah, I mean, I'll assume this is going to be for multicentric Castleman's disease. And if we're confident on the diagnosis of multicentric Castleman's disease and a patient's on siltuximab and feeling great, I actually don't care too much about the lymph nodes. Usually they get a little smaller, sometimes, half or even in few patients completely resolve. But in a lot of my patients, they don't completely resolve completely, or you'll still see some residual masses on scans. And I know it can be concerning, but I always try to reassure my patients that there's nothing really to worry about. We're treating, if you're feeling better, that's a win. And so I tend to not fixate on the lymph nodes. Now, it would be unusual. I haven't seen it where the patient's responding and there's a rather large lymph node that's actually bothersome because it's so big and bothersome. And if that were the case, I would even consider rebiopsying that one specific node to make sure that we're dealing with Castleman's and not something else.
Awesome. Thank you, Dr. Goodman. Another question is, what is the next step of treatment if your treatment you're on doesn't work for you?
Well, that's a very complicated question. So first, it depends largely on what treatment you've received. This is, really the case with any cancer or cancer-like diagnosis, what treatment you've received and how you are doing. What are your other medical problems that are occurring? Typically, if this is in multicentric Castleman's disease, the majority of patients, at least I hope, now are receiving siltuximab frontline as their first option. And if this is a patient that is progressing on siltuximab, first I want to make sure they're really progressing on siltuximab, rule out anything else that's going on. Again, if imaging has something peculiar in it that just doesn't fit the book, just because I've seen patients misdiagnosed with multicentric Castleman's disease get put on siltuximab, feel better, but siltuximab is anti-inflammatory, so any sort of other inflammatory disease might respond to it. Even infection, I've seen a case. I always rebiopsy, regroup, make sure the diagnosis is correct. And then if I truly feel it's a siltuximab failure, it depends, a failure of siltuximab. It depends on the pace and if you're in the hospital in the ICU with fluid overload and kidney failure and all sorts of not so great things, then there's a place for a lot of steroids and potentially even chemotherapeutics. But if it's a more indolent type of relapse, I usually go to rituximab. There's no right answer. We don't have any randomized studies in this, but I usually try, now I would refer for Dr. Feigenbaum's great study. That is actually my first go-to. And if that's he has a sirolimus study, which I think everyone should enroll in if they have access to it. But if they can't get on that study, I've been using rituximab, or in some patients, even sirolimus off-label, and you can usually get it. But I would probably do rituximab first. And, then you just go through them. If they respond or don't respond to it, there's just all sorts of other agents. And I try to use the least toxic, most palatable regimen that I can give. I don't know if David wants to add anything. There's a whole, we could talk for an hour on how to treat relapsed Castleman's disease.
Yeah, absolutely. And I'm glad that Mileva put in the chat our treatment guidelines. So, those guidelines were written for physicians, and it's published in the journal Blood, but they are absolutely publicly available. We paid to make them open source, so anyone can click and look at them. You can look at the treatment guidelines, and what you'll see for IMCD is that regardless of how severe you are, we recommend IL-6 blockade with siltuximab first. So that's the first thing we recommend for everyone. And then, as Aaron said, if you're really sick and you're getting worse on siltuximab, you might need chemotherapy. If you're not really sick, like you're not in the ICU and you're getting worse on siltuximab, and if a couple months have gone by, that's when you want to think about rituximab. You want to think about things like sirolimus, potentially joining the trial for sirolimus. The thalidomide's on that list. So it gets challenging after siltuximab. I mean, I have to say that's really where we've spent a lot of our effort as an organization. a lot of blood, sweat, and tears has gone into what do you do for people that don't benefit from siltuximab. And the good news is that about 1/3 to 1/2 of patients do benefit on siltuximab. The tough thing is that that still means that there's people left over like me and some of you on the call. So we're still fighting to figure out all the right answers for those patients. I'll actually also put a link in the chat. I put a link to the IL-6 paper. I also put a link to a paper we just published on treatment in IMCD.
Great, thanks, David. Another question, and I guess this can go for anybody. Patients who have other comorbidities, and then through, battling other things, they end up finding out that they are also diagnosed with idiopathic multicenter Castleman disease. This particular patient also had COVID. And so have we seen any correlation between, honestly, any of the comorbidities, but this specifically would be sojourns, a COVID flare, and then also being diagnosed with Castleman disease?
Yeah, I mean, the immediate answer is that yes, we do see a lot of diseases getting misdiagnosed as Castleman's or being diagnosed with Castleman's. So Sjogren's syndrome, we just had a recent debate within our advisory board around, can you have Sjogren's and Castleman's, or if you have Sjogren's, that means that you don't have Castleman's. And we decided, it's complicated, but generally that yes, you can have both Castleman's and Sjogren's. But the point here being that Castleman's can look like a lot of inflammatory diseases. So it can look like lupus, it can look like lymphoma. And so there's a bit of a debate. Can you have both lupus and Castleman's? Can you have lymphoma and Castleman's? Some doctors will say you can't have both. If you have lymphoma and you have something that looks like Castleman's, you really just have lymphoma. Or if you have lupus and something that looks like Castleman's, you really just have lupus. Some doctors say, no, you can have both. And I think the challenge is that there is no answer book. Like, we don't know what the right answer is. We just know that that those are complicated. If you have two things happening at once and one of them's Castleman's, it's complicated to know what to do. And in terms of COVID, Sai, who's on the call, has done a phenomenal job leading a study looking at the experience of Castleman's patients when they've experienced COVID, the illness of COVID, also around their COVID vaccine. It's a really great study that he led that we actually got good reviews from a journal called Blood Neoplasia. So I think that'll end up getting published. But the key takeaways from that paper are that patients with Castleman's get COVID, which is not surprising. We're not surprised by that, but those who do get it do not seem to have a particularly bad COVID experience. We were all afraid. I don't know about you, but I lived under a rock for 2 years at the beginning of the pandemic. My wife, kids, and I, we didn't do anything because we were so afraid. Turns out the data suggests that either we all did such a good job hiding under rocks during the pandemic, so that's why we all did pretty well, or it's that COVID doesn't really cause really bad outcomes in Castleman's patients, which is what we were worried about. And so that's really the takeaway of Sai's paper. The other takeaway is that Castleman's patients tend to mount a good response to the vaccine, which is another thing that we were worried about because we're all on different drugs that suppress our immune systems. So maybe we get the vaccine, it doesn't do anything. Well, it turns out that if you measure antibodies in the blood, we actually do make antibodies. So those of you that were part of those studies, thank you. If you're part of Accelerate, you fill out a survey, or if you send in your blood samples, thank you for doing that, because these are important things for us to all be aware of.
Yeah, for those 2 points, I'm actually very opinionated on one of them. So if you don't mind me sharing my opinion on it, but first with the COVID, I don't know if your data looked, so like with I don't think personally having Castleman's and being on siltuximab, you have worse COVID, at least from the data and experience. But for those patients on rituximab, did you guys look at that specific group? Because I use a lot of rituximab in lymphoma. In rituximab, definitely we saw potentially more scary outcomes from patients on especially early in the pandemic. And right now we're actually not seeing much, more so early in the pandemic.
I think it was small sample size is part of the problem. Out of the 100 or so Castleman's patients in our study, I think only 16 got COVID. Out of the 16 that got COVID, only a couple of them were on rituximab. So there was no clear rituximab signal, but maybe if we had 100 Castleman patients on rituximab, maybe we would have seen it. But yeah, I think we all agree conceptually being on rituximab certainly should make it harder to fight COVID. But we didn't necessarily see a big signal for it.
Yeah, and at least from because they looked at for drugs that are really active against lymphocytes, which are lymphomas and rituximab, steroids, those seem to be across the hematologic literature more concerning for severe COVID outcomes, while drugs that were directed, like there's a bunch of diseases that I treat called acute myeloid leukemia and other non-lymphoid malignancies where they actually didn't seem to have as bad of outcomes with COVID. So that's reassuring. And so siltuximab should have no reason to, I think, have a bad outcome. Now, as far as can there be two diseases that coexist, we have to remember what idiopathic multicentric Castleman's is. And David's desperately trying to figure out exactly what it is. And I really hope in my lifetime we do. But it's not a diagnosis. It's we don't know. We know it's not something else. And you fit this criteria that David and a bunch of other experts came up with, and it's useful and it allows us to treat these patients. But it's basically in the lymph node, when the pathologist looks under the scope, they say, okay, there's findings consistent with Castleman's features. And you don't need to know the specifics. And you can see those findings in idiopathic multicentric Castleman's disease, but you can also see them in a crap ton of other diseases, okay? And once you rule out all the other diseases, you then call it basically IMCD or idiopathic, but it's still caused by something. There's still a reason why. We just don't know. And in those cases, we treat with siltuximab and we go down the pathway. But there are many other diseases, including infections. I won't go into the details, but I had a patient with an atypical infection that was seen by numerous physicians, started on siltuximab, transferred care to me, and was actually doing okay on it, and then wasn't. And it ended up being an infection. The infection triggered Castleman's-like findings in the lymph nodes, and we couldn't find the infection at first go round, and we missed it. So if you have another diagnosis, like Sjogren's or an autoimmune disease or a lymphoma, I think right now, I think we should definitely treat that condition, okay? And not treat the Castleman's at the same time. Now, if you treat that condition and it doesn't get better, then scratch your head and reorganize. Are we screwed up on that? Is that not the diagnosis? Or if it does get better, I suspect the lymph nodes and the Castleman's findings will get better. But in a peculiar case where that condition got better and there were still residual lymph nodes and inflammatory symptoms, which I have yet to see a case of that. And if there is, someone can share it with me, then I guess you could treat the Castleman. So bottom line, treat the when I see a Castleman's patient, I spend what I've learned, I spend hours and days really fixating on the fact that I'm not missing something, because now that Castleman's is more, people are now more aware of it because of some of David's work. There's a lot more referrals, and I would say a lot of them are not Castleman's disease and end up being something else. So personally, no, treat the underlying condition. Now, as far as comorbidities, no, there's no direct link that I'm aware of, like if you have heart disease, diabetes, or anything like that, that there's a correlation with developing Castleman's disease. I don't know the literature off the top of my head, but I suspect there's a link between autoimmune and some of these other things. But as I just said, those cases are probably true autoimmune disease with some Castleman's features in the lymph node and not Castleman idiopathic MCD.
I agree. And one thing I just add to it, Aaron, is the certainty that we like to have in medicine, where we like to be like, this is this thing and it is not this thing, is really, really hard in Castleman's. In fact, I've been doing this, for 13 years, and my certainty has gotten worse as time has gone on. And what I mean is that the more I see and the more lymph nodes I look at and the more time I spend with experts who spend all their days looking at lymph nodes, the more I learn that you can have like the 5 world's experts who literally all they do is spend all day long looking at lymph nodes and give them the same lymph node. And you can get, the joke is that you can get 7 opinions from 5 pathologists about the Castleman's lymph node. I've only gotten 5 opinions, but you can literally get 5 different ideas. One says it's definitely Castleman's, one says it's definitely not Castleman's, another one says it might be, another one says it's definitely this other thing, another one says it's nothing. And you're like, wait a minute. So that means that if your lymph node gets to one of those 5, then you get one answer. If it goes to another one of those 5, you're gonna get another answer. And then if you come to the experts, even the experts can't agree. And so the bottom line is that it's a tough diagnosis to make. As Aaron said, you got to make sure that the things that can kind of look like Castleman's, that they're evaluated and that they're ruled out. And it's not to say that what we have is not a thing. We all have a thing that's causing a problem. It's just that we don't have a very good test. Like so many other diseases, you can look for a mutation in a gene and you say, yes, this is definitely that. Or you can look for a blood test, say, this is definitely that, because that thing defines the thing. But in our disease, we don't have a specific test to define what is this entity. And so that's what a lot of our research is focused on. So we just got back some data where we're doing genetic sequencing of lymph node tissue. So if you're part of the registry and you gave us your lymph nodes, we're sequencing your lymph nodes right now. That's unicentric and multicentric. We're also working to do sequencing of blood if you're a multicentric Castleman disease patient. We've done a bunch of autoantibody work, done a bunch of pathogen discovery work. We want to find that thing so that way we can just do a test for the thing that's a blood test or a lymph node test and not be in this state of confusion where doctors are disagreeing with one another.
That sounds great. Thanks, guys. One of the questions that was asked kind of ties into the various treatments, but essentially there was a patient who started on Rituxan. It helped with his ascites. It then stopped after they started it the second time. They switched to siltuximab, have been on it about 3 months. It is not touching the ascites at all. So the doctors are wanting to switch to something else. Not sure what that something else should be. And also, is the lack of improvement in ascites an indicator that siltuximab is not working for them?
Well, I think, it depends on, are the others, was ascites the only symptom? Are the inflammatory symptoms and all those things better? That would matter. And if it is, I would definitely have the patient see a liver doctor. There are many causes. So ascites is, if for those who don't know, it's fluid in the belly, shouldn't be there. So not like in the stomach, your abdominal organs sitting like a purse, and you can get fluid buildup in there. And Castleman's can cause that, but there's an entity called portal hypertension or high blood pressure within the vessels in the liver, and there are many causes of that. And I would want to make sure that's investigated to make sure we're not missing something else that happened. But I would say if the siltuximab is working with all the symptoms, I would give it longer, and temporarily you can drain the ascites using procedures or give medications. But it would be hard for me to want to change therapies if the patient's feeling much better, labs are better, but there is just some ascites that's left over.
Yeah, the only thing that I'd add to that is that, and what Aaron's saying is that you want to look at the constellation of all of your Castleman's things and see if all of them are improving. So like when you're sick, let's say your CRP is elevated, you got fluid in your belly, your hemoglobin level's low, you feel tired. Those are the things that make up your Castleman's, those 4 things. And if you see that 3 of the 4 are getting better and the only thing left is the ascites, then that's a good sign that you're controlling the disease, and therefore the ascites should go on to improve. But like if nothing's getting better and you still have ascites, generally problems in Castleman's tend to move together. So if you're treating the heart of the disease, the other stuff should improve. I put a link in the chat. We published a paper a year or so ago where we reported on the timing until various things improved. And what we found is that ascites was one of the or fluid accumulation generally was one of the last things that improved. And so if you pull up that link, the one that's
Can you send me that paper? I need that one. That's a good one.
Yeah, I just put it in the chat. It's the one with PubMed. And if anyone wants to look at it, here, I'll actually share my screen really quick. It says disabled screen sharing. Mel, are you able to give me permission? Cool. All right, I'm going to do this really quick. Great. So if you look at this figure, what you'll see, and these are the patients who responded to siltuximab, that within a month, patients' platelet counts improved. Within a month, a lot of symptoms improved. Within 2 months, CRP was normal. Within 3 months, albumin levels were normal. 3.5 months, hemoglobin levels were normal. By 4 months, lymph node size had shrunk down. By 8 months, ferritin levels had improved, and by 10 months, IgG levels improved. And sorry, this actually doesn't point out ascites, but I thought I remembered that ascites is one of the lower ones. So sorry. I think if we dig in this paper, I think fluid was one of the later ones. But sorry, this paper actually doesn't show it. It shows when lab tests improved. So apologies.
Awesome. Thanks, David. Anything else you guys wanted to add to that question? Okay. One of the questions that was asked, and I'll let both of you guys weigh in, but also just wanted to weigh in myself. It says, should we see a Castleman specialist to ensure that everything is okay? So as our organization, we always recommend that our patients try to connect with a Castleman expert. As many of you have learned through your journey, it is still something that is not well known to the regular physicians that are operating in all of your hospitals. Not that they're not capable, they're absolutely capable, but if they want to be able to connect with one of our physicians themselves, or if you want to just make sure that you have that initial consultation with one of our expert clinicians, we always recommend that. You're going to get such great ability to connect with our organization of people who are literally in tune with the CDCN, who are on our scientific advisory board, who, you know, work together to try to drive forward our life-saving research. And so we always recommend that. That's wonderful. We do also recognize you probably not all of you are able to get to one of our expert clinicians. That does not mean that you will not be just as well taken care of. That's why our organization exists. So if you can't get to one, you reach out to us and we will absolutely help make sure that you have all of the resources that you need to continue to drive forward the education that you need, and also things that you can share with your physicians as well. And David or Aaron, I'm not sure if you guys wanted to weigh in on anything with that.
I mean,
No,
you know, oncologists have a tough job. They treat a gazillion different, many are rare. And you know, I treat Castleman's, but I treat all heme malignancies, and it's hard to keep up. So I think what's most important, if able, not that you need, anyone can give siltuximab, it's really a piece of cake. And chemo, they're all skilled at giving these drugs. But I think it's worthwhile if you can to get at least one, you know, having now done this for 6 years, like, I think back to when I started, I didn't know what I was doing, you know. I mean, I'm being honest. I would have screwed up a lot of that stuff. And with the experience, I feel much better. So if you can get a one-time look over, I think it's beneficial, especially to agree with the diagnosis. And, you know, a lot of the expert centers usually have one person that sees it in most states. And now with video visits, with your, like, if you live in California, like, I can see you on video without, but I'm not allowed to see you if you live in Nevada or whatever. So I think that should be able for most people to do at least once.
Great, thank you. Another question, can you guys weigh in on the effects that drugs and alcohol have on Castleman disease?
Well, you know, drugs and alcohol aren't good for you. But what I tell my patients is, you know, like, if you have a few drinks, you know, I don't think it's the end of the world. You know, your quality, for me as an oncologist, the two most important things for my patients is what I'm doing for them, making them live longer and live better. Okay. I don't care about anything else. So if having 1 or 2 beers a week makes you live better, then I'm cool with it. So there should be no reason. It doesn't, depending on your platelets and liver function and all those things, that would go into it. Now, drugs, I mean, there's a lot of, I mean, I don't really recommend any drugs, although when it comes to marijuana, I don't see a reason why that would be a huge issue. I wouldn't smoke it. Smoking's bad for anyone. But I'm pretty liberal when it comes to those things. Maybe David has another opinion.
No, I think that there's, you know, limited data one way or another. And I think that I can tell you as a Castleman's patient that at times didn't think that I'd be here for very long, that, you know, while I'm here, like, you know, I think that we should, you know, do things that make us happy. And, you know, if that's, having a couple glasses of wine, I don't think that that's a problem. I will make a bit of a pitch to you guys, and I don't know if pitch is the right way to describe it, but I'll tell you something I've fallen in love with over the last year. So I don't know if you guys can see it. It's called the Whoop. And I do not work for Whoop. This is purely my own personal experience with the Whoop. But so the Whoop is constantly tracking your heart rate, the time between heartbeats, your respiratory rate, your pulse ox, your body temperature, like all day, every day. And it's basically tracking your state of health. So surprisingly, our vital signs change, like our respiratory rate, our heart rate changes based on how, like, our state of health. And so it gives me a score every day for like how healthy I am that day because of my vital signs. And I can tell you that the number one thing that'll cause your vital signs to not look as good is to drink alcohol. So, you know, we all know that, but like the data tells you that. And you know the reason I love it is a couple reasons. So a few reasons. One is that it gets me to sleep more than I did before I had the Whoop. I think you guys all know I work like 16 hours a day on a easy day, right? So I work a lot. And I love to work, and I wouldn't sleep if I didn't have to sleep. I don't want to sleep. I like want to do the work that I get to do every day. And so the Whoop, of course, my vital signs are bad when I don't sleep. Like it's just so I get like all these alerts from my Whoop telling me that I need to sleep more. And so one, it gets me to sleep more, which is a good thing. And then two, the one I really fell in love with the Whoop was a few weeks after I got a score. It gives you a score from 1 to 100 on your state of health. And I got a 1 one day. And I didn't feel that great, but I was concerned. I have Castleman's, and all of a sudden my Whoop is telling me I'm like the lowest possible score that you can have. And so I called my doctor and he said, well, why don't you come in? And so he came in, did a chest x-ray, and determined that I had right lower lobe pneumonia, like very serious pneumonia, that I got on antibiotics. And if I hadn't had the Whoop, I just wouldn't have called a doctor for a week, and I would have been really sick. I might've been septic. I certainly wouldn't have responded so quickly to oral antibiotics. And so for people like me that are stubborn and not necessarily paying attention to your health, if you have something like the Whoop, then it will pay attention for you. So anyway, like I said, I have no connection whatsoever to the Whoop, except that I have a deep love for it ever since it warned me that I had a right lower lobe pneumonia. So anyway, all that, I only brought that up because of this question around alcohol and drugs. I think doing things that are good for your body are good for your Castleman disease. And I think we all sort of know what's good for our bodies, but some of us are so stubborn that we need to have a thing on our wrist to tell us what to do. But maybe you all can just do it on your own. I need something on my wrist to tell me to do it.
And I actually did put the link to what Whoop is into the chat if anybody is interested in learning a little bit more about it. Okay, next question. Why isn't Castleman disease considered a cancer?
So cancer, cancer is a disease, that's what I talk, remember Jurassic Park, the DNA in the cells, so cancer is a disease of your code in the cells, and the DNA is the code, and it's like a computer code, and it makes, you're all born with this code, and with time, as we all age, that code, the DNA, can acquire errors in it. And those are what we call mutations. It's actually happening all the time. You have a gazillion cells and you're actually making gazillions of blood cells every day. And it's actually quite amazing that we all don't get cancer more than we do. But the body has remarkable features in it to prevent the development of cancer. But what happens is these cells in the DNA, they acquire errors in the code, and due to random chance for the majority of cancers, that error, that mutation makes the cell misbehave. And when I say misbehave, maybe it can grow faster than it's supposed to, or maybe it forgets how to do its normal function. And then it acquires a kind of a competitive edge over the other cells, because now it's growing faster or is unable to die like it should. Normal cells die within a certain amount of time, and then they start to outcompete the healthy cells. And that's what a cancer is. So a genetic disease. Castleman's, to our knowledge, at least we don't think right now, we've done all sorts of studies to look for mutations. We don't find really in the majority of cases of IMCD mutations that lead to the development of that cancer. So it's not a neoplastic or cancerous condition. Now, it's similar in the fact that the immune system, the white blood cells, are acting poorly and overactive, but it's not, to our knowledge at this point, due to an error in the code of those cells. I hope that kind of makes sense. David, anything to add?
Yeah, I totally agree. So, although one thing I would add is that that's based on our knowledge today, right? And so in a month or in 10 years or 100 years, we might actually uncover those mutations in the code of your immune cells that would make us say that actually this does fall into the category of what we would call cancer. But based on what we know today, I totally agree. There's not sufficient evidence to say that the reason our immune cells are behaving badly is because they've acquired mutations like we see in cancer, and therefore this is cancer. Right now, our immune cells are behaving badly. They're doing bad stuff. We still don't know why. We've hypothesized there's 4 things. One is that you were born with something wrong in your genetic code, which makes them basically predisposed to behave badly. That's one potential cause. Another is that you've acquired changes in your code over the course of your life, which is what Aaron was talking about, that makes them behave badly at a certain point in life, like you were healthy and then you got sick. A third possibility is that you have dysregulation of your immune system. Basically, your immune system isn't behaving properly, and so you start making antibodies against your own healthy cells, and that's called an autoimmune disease. And the fourth possibility is that there's some pathogen, like a virus or a fungi or bacteria or something, that's really responsible for this whole thing. We've looked into all 4 of them and have not found a smoking gun yet. And so there hasn't been this like very clear, okay, it's definitely this or it's definitely that. But to Aaron's point at the very beginning of the webinar, there is something, right? All of us were healthy until we weren't healthy. So there's something that changed, or something that either was there all along and just lurking, and we will find it. If you asked me, I was talking to Barbara about this a few months ago. So, if you asked me 13 or 11 years ago when you started the CDCN, would you have figured out the causes of Castleman's, or would you have figured out treatments for it? I would have said much more likely we would have figured out causes and much less likely we would have figured out treatments. But the opposite has happened. We've actually figured out treatments that many of you all are on and are helping patients, and we still don't know what causes it. So I'm not very good at predicting things. But yes, I guess that's the order I would want, but that's not what I expected.
Yeah, I think what even makes it more challenging is it's possible it's multiple of those mechanisms. Maybe
at the same
you
time,
all have some inborn slight mutation that doesn't cause problems until you have a second hit, like some weird infection or who knows what. And then to further complicate it is, as I said earlier, IMCD might, as we learn more, there might be a collection of different IMCD causes as we pull apart this puzzle.
Yeah.
Thank you. Next question is, should your weight be a factor when you're receiving siltuximab, or honestly any treatment for Castleman disease?
Well, a lot of patients gain weight on siltuximab, and that's because when they come, they're sick from their Castleman's, and then they're feeling better. Now, whether it's all that, there's something siltuximab. I mean, if you look at the studies, that the cholesterol levels can go up in patients. So, regardless. It's not healthy to be overweight. And in my experience, most patients with Castleman's on siltuximab who are responding to siltuximab seem to respond forever, okay, or for a long time, at least to our current knowledge. So, it's very likely, yeah, your Castleman's is fine, and then you get all the problems associated with being overweight. So I typically check cholesterol levels, maybe once a year, every few years, for my patients on that, get them on appropriate cholesterol lowering medications if needed, and encourage exercise and weight loss if they get overweight.
Great, thank you. Another question is it safe for our Castleman patients to receive the flu shot? Some people who have gotten it said they felt weird after the fact and wasn't sure if that's going to be something that's going to cause them to have a flare. Is there any correlation between the two?
I'm aware of no correlation. Are you, David?
No correlation that we're aware of. But I mean, all these things you sort of don't know until really in-depth studies are done, but no correlation at this stage.
Great, thank you.
We did look at things like timing of diagnosis with Castleman's, timing of flares and relapses to see if there's any seasonality to it. Like, let's say we saw a lot of flares or diagnoses in the flu months, then maybe it could be after flu vaccines, but we didn't see any sort of clear signal that Castleman's is either diagnosed or patients relapse at one time of the year versus another.
Another question is, why are there no treatment guidelines that are out for HHV8 positive patients?
That's a great question. I think part of the reason is that rituximab has been so effective for so many patients, whereas siltuximab is effective in about 35 to 50% of IMCD patients. Rituximab is effective in more like 80 to 85% of HHV positive MCD patients. And so there's just less head scratching cases to be like, what do I do now? So I think that's led to less clinicians being curious about what do you do next, because 80 to 85% of their patients respond well to rituximab alone. For the patients who don't respond to rituximab alone, chemotherapy with either etoposide or liposomal doxorubicin is typically what's recommended second line. And so though there's not a formal guideline that says that, and then I think you probably would put tocilizumab as third line. That's sort of what, at least that's what doctors are doing. So if you have HHV8 positive MCD and your doctor's not experienced or not sure what to do, please connect with us. We can connect you with some great doctors that treat HHV8 associated MCD, and I'm sure that they're going to follow that guidance. But yeah, it's a great point that, I think it really is just because there hasn't been so much confusion in the HHV8 positive cases that's led doctors to say, we're going to really put our heads together. But Aaron, I don't know if you have any other thoughts.
I think the NCCN might have an HHV8 page.
I think you're right. I think they do. Yes,
And
I think it's rituximab, then then liposomal doxorubicin or etoposide.
Yeah, it's basically, yeah. And single agent, they published the long-term data on rituximab
Amazing.
and that, and it's most patients don't relapse, and it's just a different, because that one we know the cause, right? It's HHV8. It's doing something, and their lymph nodes have these Castleman's findings, but it's really it's similarity, but it's different. We have a good treatment for it. So, which is good, but yeah. So I do think those guidelines exist in the NCCN under the lymphoma guideline. There's a B-cell lymphoma guideline that has those buried in there.
You're right.
Great, thank you. Another question is, how does low white blood cell count and absolute lymphocyte levels factor into diagnosis?
Not currently part of the diagnostic criteria for any form of Castleman. So you might have them, but they're not required to make the diagnosis. Some patients will have low white blood cell count. Other patients will have very high white blood cell count. Many patients will get steroids, which will cause your white blood cell count to go up. And so it's not necessarily your Castleman's, but maybe it's the steroids you're on. But right now it's not a requirement. Though some people can have it, it's certainly not required to make the diagnosis.
Awesome, thank you. Have you ever noticed an increase in estrogen in males that have IMCD?
I've never checked. So no.
That's something we could look in the registry. I don't know. I see Sai's on, and Criswell's on too. We could look to see. I think that most doctors probably are not checking estrogen, so therefore we're not going to have the data unless it was measured. But I suspect some patients have. So Sai, we could just do a quick search of Accelerate. Anyone who's on in Accelerate, we can use your medical records to look for that data, and we can pull that up and we can share it at our next community gathering.
The last question that I see in the chat, so if anybody else wants to throw something in before we wrap up tonight, please do now. But last question that I'm seeing is there any evidence that shows severe abdominal pain or throbbing pains as a reaction to siltuximab or sirolimus?
I haven't seen it. I have not seen it.
I haven't either. And if you're getting it with both drugs, then that would make me more concerned that it's not the drugs that's causing it. If you got that just with one drug or got it with another drug, but if you're getting the same sort of abdominal pain on two completely different drugs that work in completely different ways, that would make me more concerned that there's something going on in your abdomen that's unrelated to the medication.
Great, thank you. Another question that was asked is, what do you usually suggest to patients that have UCD? It's been fully removed, but they still have symptoms like low hemoglobin, elevated CRP, bad fatigue. What recommendations do you have?
If it's truly UCD, unicentric Castleman's disease, those symptoms should never have been there in the first place unless there's something else going on where the diagnosis, UCD, almost by definition, it's in one or spot or a few lymph nodes right next to each other, and you're otherwise asymptomatic and you cut it out, or in some cases you can just follow it and everyone's happy. So I would strongly explore you shouldn't be anemic and have inflammatory symptoms.
Well, Aaron, the only thing I'd say about that is that in about 10% of patients, you can see, an inflammatory syndrome. It's rare, but in unicentric Castleman's, you can see in about 10% of patients like a true inflammatory syndrome, but it almost always goes out when the lymph node comes out. So in that rare case where you do have the inflammatory syndrome, you cut it out and it should all go away. It would be very unusual for you to have those inflammatory syndromes, you cut out the lymph node and then they stay around. And again, when I say inflammatory syndrome, that means that you've got an elevated CRP, you've got a low hemoglobin, there's sort of these laboratory changes. I did put a link in the chat to a paper that Mateo led, where we found that a lot of unicentric Castleman disease patients report having continued symptoms after their lymph node comes out. And so that's sort of new to the field. We'd heard a lot about it. Mateo did a lot of great work to get that data together. So unicentric Castleman disease patients continue to report symptoms even after the lymph node comes out. But to Aaron's point, it's much less common for someone to have, rip-roaring inflammation like an elevated CRP and a low hemoglobin. And it's even less common that once that gets cut out, that those things stick around.
Awesome. Thanks, David. David, I'll throw this one to you. If you're part of our Accelerate registry, should the doctors be forwarding test results over to us every now and then?
should the doctors be forwarding to the Accelerate team?
Yep.
Your doctors don't need to do that. Chriswell, who's on the call, does a really great job of following up with your doctors to get records. So it might be every year, might be every year and a half, but we do the follow-up. So as long as you're in the registry, fill out your forms every 3 months when you get those emailed to you, and then Chriswell does the hard work to make sure that we have those records, and then Sai and Mateo also do hard work to make sure those records get into the system.
And I'll just mention this because it's something that happened more recently. If for whatever reason you're having an issue with that survey that comes to you, that's why our team exists. So if you try to take it and you can't get back in, you forgot login, you don't know how to do it, you're not sure if you're putting in the right information, always make sure to reach out to us. I know sometimes you're not seeing changes, there's not much to report, but those surveys are sent and it really allows our team to see even the tiniest change or get the last time you were in your doctor's office kind of information. And so if you can't fill out the form, if you can't get your survey link to work, just let us know. That's why our team exists. And Chriswell's fantastic about really leading that charge and ensuring that she's helping all of you guys. I do not see any other questions. Is there anybody else on the call have anything else you want to ask both Dr. David or Dr. Aaron, who are here tonight with us, giving us their expert advice on all of things Castleman disease?
I guess I have a question. I'm not sure because you said I just saw Dr. Van Ree and he said that I had unicentric, but it's underneath both of my armpits. And so if they're not directly next to each other at the summit, I think it was kind of made it seem like it was more multi. And I just am confused. And I didn't get to see him for very long, so I didn't get to ask a whole lot of questions. So I didn't know if somebody could clear that up or.
The great question. So where we are right now is that we always thought that either you had unicentric or you have multicentric and there was no grayness in the middle. But over the course of the registry, it's become clear that somewhere around 5 to 10% of patients will have what we sometimes call regional or oligocentric Castleman disease, which means that the lymph nodes look like UCD, but to your point, they're in a couple places. So it's not really multicentric where you got a bunch. They're in a couple places. It might be two regions, two armpit regions. It might be that you've got chest and cervical, but it just doesn't really fit the picture because again, it's not just one or it's not 15. It's two, and so we call it oligocentric, which means few sometimes. But we still haven't had that paper come out yet. But yes, you sort of.
David, I need to see that paper. I mean, in that data, are both those nodes biopsied, or I would be, and when you say two separate regions, one armpit and then the opposite armpit, or it'd be very granular with that data. So I'd like to see it when you guys publish.
Yeah, no, absolutely. We'll share it with you. And yeah, the distribution is interesting. It's a lot of sort of contiguous. So it might be right cervical and hilar, but it also might be both armpits. And what we found, which was very clear, is that the patients with just two enlarged regions, though that's technically multicentric, they behaved almost exactly like a unicentric Castleman disease patient. So 2 regions of enlarged lymph nodes in our data set equals the symptoms in the lab test that you would expect to see in a unicentric Castleman disease patient. So that's, I think, why Fritz might have said this is unicentric, is that yes, when we saw patients that have 2 enlarged lymph nodes, 2 is greater than 1, which in the past used to mean multicentric, but now it appears, at least from this data, that 2 is more like 1, and that really you need to have more than a couple to typically behave like a multicentric patient.
Awesome. Thank you, guys. Another question that was actually just asked while you guys were talking, and this is actually something that's been brought up several different times in various community gatherings that we've had. Is there any updates that we've had as a team on the ability to accept body donation upon one of our patients passing?
We haven't made too much progress on this. Crystal, we should loop in Bridget. I know we talked about this a year or two ago. I and a few others have expressed interest that whenever it is that we pass, hopefully a long time from now, that we want to contribute, our organs to Castleman's research. And this actually came up sadly with a patient a little bit over a year ago. And we didn't have the infrastructure in place to do that. And so Chris, let's take it offline to connect with Bridget. And we did speak with a company that does this. They're actually a nonprofit organization, And the prices that they were going to charge to help with this were really astronomical, like $100,000 a year just to have like the system in place, not even to necessarily help with a body donation for research, but just like to keep them ready if we ever needed help. Which is like, we can't afford that. So anyway, we're going to keep looking into it. I have to believe there's a path forward that doesn't require $100,000 a year. And I think it's the kind of thing that like none of us want to actually look into, right? Because like, none of us want anyone's bodies to be different. We want to all, living healthy for a long time. And as Aaron said, well and happy. But it is something that we do need to look into further. Maybe we can find another company that we can set this up. So if anyone wants that to be something that would be done, those are the kinds of donations that obviously would really help us to make progress against this disease.
Thanks, David. One final question, and then we're going to say goodbye to our community tonight. If a patient is on Sylvant infusions and their IL-6 level is over 1,000, does it make sense for them to be changing out of that medication? I think their current physician wants to switch them to rituximab. Like, what would be the best path forward in a situation like that?
So this is exactly what I was saying at the beginning of the webinar. So if you're on siltuximab, don't pay attention to your IL-6 levels at all. Like, pretend they don't exist. Like, don't and tell your doctor to not look at them. So if you're on siltuximab and you've had your IL-6 measured, close your eyes and put your fingers over your ears if someone tells you anything about IL-6 levels. So again, forget the IL-6 levels if they're on siltuximab. If there's other things that are up and that are abnormal, worry about that, but don't worry about the IL-6 levels. Dan, or I don't know if you saw at the very beginning, I'll put the link in the chat again. We just published a paper that very clearly says that just taking siltuximab causes your IL-6 levels to go elevated, but not actually to go elevated. Just the test thinks that they're elevated. So don't pay attention to the IL-6 levels.
Great. Thanks, David. Okay, well, I personally want to thank both David and also Aaron, Dr. Goodman, for being here with us tonight. Obviously, your expertise in this field is invaluable, and I know that our community is super thankful from being able to have a session like this where they're able to come on and just ask questions. We always try to use these community gatherings to share data with you. But we really wanted to be able to allow you guys to come to us and just ask anything that you have. So to both David and Aaron, thank you for your time. Thank you for giving us your expertise, and thank you for allowing our community to ask anything from you guys. And then to our community, you guys know how much I love you. So it's always a pleasure to be able to see you guys, see your faces, and just be able to be here with you guys more so than once a year for our summits. I'm going to kick it back over to both David and then also Dr. Goodman for you guys to say anything final.
Sure. I'm just going to make just a quick comment to Dan R. Just feel free to reach out to us or have your doctor reach out to us if you're unsure what to do with IL-6 levels. But again, don't pay attention to them. But if your doctor's paying attention to them and doesn't know what to do, just have that person reach out to us so we can put email addresses in the chat. Happy to be helpful any way we can. And then to the whole community, we just love you guys all so much, and we think about you guys all the time. So don't ever hesitate to reach out. We're always thinking about you. We're always working on your behalf, and we've got an amazing team that's doing that. So please reach out if there's ever anything we can do. If you're ever unclear about anything, we're always here. Yeah, maybe I'll turn it over to Aaron for any final parting words.
Oh, thanks for having me. These are, for me, the best part about being a physician is getting to teach and educate patients and make you guys, knowledge is power. So thanks for having me. Happy to help anytime in the future.
And we can't close anything without a Castleman flex. So I'm going to ask anyone who is decent enough to turn their camera on to turn your camera on so we can get a Castleman flex in together. And again, don't turn your camera on if you're not ready to turn your camera on. But let's get a flex in with anyone who wants to flex.
And David, I'll do it so you can lead the flex. I'll take the photo, you lead the flex.
Photo. It's always a good time for a flex. Are you guys ready?
Awesome.
Nice. Good team. All right, everyone. Have a good night.
Have a great night.